All right, well, good morning, everyone. It is my pleasure to introduce Dr. Allison Hall, who will be doing the ground rounds for this morning. Dr. Hall is from Newfoundland, Canada. In case you don't know where it is, go Google Maps. It's all the way north and to the east. And she did her training there. She trained in medicine at the Memorial University of Newfoundland and Labrador. Then she went to Ottawa for internal medicine and Calgary for cardiology and interventional cardiology. And he has been practicing as an interventional cardiologist at Eastern Health in St. John's, Newfoundland. And as he takes a break from her practice to come here spend this year with us doing advanced coronary interventions, CHIP, and CTOs. She has been doing a phenomenal job so far. And building on the theme of complexity, she's going to talk to us about a topic that is very controversial these days, the door to unload. Allison.
Thank you. Okay, good morning, everyone. It's my pleasure to speak to you today about the concept of door to unload in STEMI. So I'd like to begin with actually a very brief history of STEMI itself. So it was in 1912 that James Herrick put forth his landmark paper describing some of the clinical features of acute coronary obstruction. And to quote him, he says, "My paper on the diagnosis of coronary thrombosis during life rather than only at autopsy, which I presented at the 1912 meeting of the Association of American Physicians, fell like a dud." So this puts into context exactly how far we have come in terms of our management of STEMI. I came across a lovely review paper that was written by Eugene Braunwald in 2012, and in this paper he summarized 4 phases of evolution in the management of STEMI. Our first phase, looking back to that 1912 paper, extended up to about 1961 and could be best termed the bed rest and quote-unquote expectant treatment phase. So essentially, as we know, patients were given bed rest. This was up to 6 weeks or so at a time. They were given emotional rest as well, and you read descriptions of how they'd be placed far away from nursing stations to avoid the hustle and bustle. They'd be given medications like morphine, digitalis, etc., and later anticoagulants into the 1950s. And again, to quote Eugene Braunwald in terms of how these patients were doing, he says, "It was not uncommon for me when arriving on the medical floor at 6 a.m. to draw blood to be sent for testing to discover that one of my AMI patients had died quietly during the night." So clearly things are not going so well with phase 1. Into phase 2, we had the development of the CCU, and this was a concept that evolved in the 1960s originally. And it involved several steps. So the first was the segregation of acute MI patients into actual intensive care units where you would have access to specialized equipment and highly trained staff. Patients were now placed on continuous monitoring to look for lethal arrhythmias, which is, of course, important. And you started to have staff who were trained in closed chest resuscitation. And also, nurses were now given the authority to initiate therapy like CPR or defibrillation in the absence of a physician. So they didn't have to wait, 30 minutes until Dr. Smith showed up before they defibrillated the patient in VF, so that was handy. So as you can imagine, the advent of the CCU, again, significantly decreased deaths from particularly arrhythmias in STEMI patients, and early hospital mortality declined from about 30% in the previous decade down to 15%. We then enter into the phase 3, coming from about 1975 to present, where of course our focus has become directed on myocardial reperfusion. And this began with the advent of streptokinase in the 1970s, subsequent development of more potent tissue plasminogen activators, the addition of aspirin and later other more potent antiplatelet agents, of course the development of balloon angioplasty and subsequently bare metal stents as well as drug-eluting stents, and the development of other adjuncts that we don't necessarily use routinely, but things like aspiration thrombectomy. And quite importantly, we evolved the concept of rapid reperfusion for patients, so achieving door to balloon within our 90-minute window, for instance. And each measure that was achieved during this phase, again, improved mortality significantly, coming down from about 15% to 7.5%. And in clinical trial series, lower numbers would even be achieved between 2.5% to 3.5%. And this graphic here nicely shows you that concept. Oh, sorry, I pressed the wrong button. There we go. So basically looking at trials published on STEMI outcomes back in the 1980s with JISI-1 with 13% mortality, right down to the Horizons AMI trial, which was published in 2008 with mortality of 2.5%. And indeed, the overall mortality for all-comer ACS patients itself has declined by about 22% in the last decade with the advent of all of these therapies and also good upstream preventative care. So this is fantastic, is it not? So we've done great. You know, we've really improved STEMI outcomes. What's more to do? We can all go home. Well, unfortunately, the reality is that acute MI patients, large portions of these individuals go on to develop heart failure. In at least one series, for instance, which was focused on more elderly individuals, about 30% of the patients during their index hospitalization with their MI had heart failure. And by 5 years out, 71% of those individuals had developed heart failure. And we know that this places significant morbidity and mortality risk for patients and also a large burden on the medical system. We know that as well, with respect to this heart failure onset, the size of your MI is an important player. So for every 5% increase in the size of your infarct, there's a 20% increase in your incidence of 1-year hospitalization for heart failure. Now, to some degree, the evolution of heart failure in post-MI patients is probably population-based as well. We know, for instance, that individuals coming with STEMI in about 2011, 2013 were much more likely to have more complex comorbidities, such as diabetes, end-stage renal disease, complex coronary anatomy, compared to their cohort even just from 2005 and 2006. But apart from that, we know that an alleged ongoing contributor to initial infarct size, myocardial injury, and ultimately heart failure onset is the concept of reperfusion injury. So although it reduces ischemic cell death, reperfusion is truly a double-edged sword because it also injures the surviving myocardium. And we know that disordered microvascular function, inadequate myocardial tissue-level perfusion is often present in patients despite the fact that we feel great when we open epicardial vessels. So this leads us to the description of the fourth phase in the evolution of STEMI care as described by Braunwald, which is quote-unquote the future, where we lend our focus towards the prevention of lethal reperfusion injury. And he also raises the question of possibly some regenerative medicine, for instance, with the study of stem cell therapy that's ongoing. So again, coming back to reperfusion injury, if we achieve timely reperfusion for patients, such as with our door-to-balloon goal within 90 minutes, we can hope to perhaps save about 50% of the patient's severely ischemic myocardium. And this has been shown in certain studies, for instance, with the CRISP-AMI study. I'm not going to go over the details of what they were looking at, but for all comers in that study, in both arms of the study, when they underwent cardiac MRI about 4 days after their infarct, despite having adequate door-to-balloon times, about 40% of their LV was infarcted. So you can see that there's a lot more at play other than simply just opening a vessel. So in terms of this effect of reperfusion injury at the coronary or microvascular level, we see changes such as vascular permeability or increased edema in vessels. We have impaired vasomotion, so ongoing coronary spasm, microembolic phenomena, stasis, intravascular cellular aggregates form. We have issues with capillary destruction and hemorrhage. And you can see here basically an illustration of this entire cascade where you have your acutely occluded coronary, you open it up with nice epicardial reperfusion, and you propagate reperfusion injury and this entire cascade of negative things that essentially occur, leading to microvascular dysfunction for patients. Now, unfortunately, as much as we're learning about reperfusion injury, it is a complex phenomenon to target effectively from a therapeutic standpoint. As of right now, there's no widely accepted, clinically, in place effective treatment for reducing myocardial reperfusion injury in STEMI, though there have been some promising studies and methods. One of the big areas in this field has been the examination of something called ischemic conditioning, which was originally described in the 1980s by Murray et al. When they took the coronaries of dogs, they transiently occluded the left circumflex several times, and then they occluded it for 40 minutes and were able to reduce infarct size by about 25%. And this has subsequently evolved to less invasive means where, for instance, you inflate and deflate blood pressure cuffs on the limbs of animals and humans and achieve reduction in infarct size. Unfortunately, although even there have been trials in humans that have showed promise, this has been something that has not translated well into clinical practice despite over 10,000 papers published on the topic. So, we know about reperfusion injury. We know a lot of its pathophysiology. Well, does it really matter for patients? Do we actually see this in clinical practice? So I just wanted to give you a brief example that illustrates that. So this was actually a patient. I was involved with his care back when I was doing my interventional fellowship in Calgary, and this was a young gentleman with no medical history who did the right thing and presented acutely with his chest pain with this significant anterior STEMI on his EKG, as you can see. he was taken to the cath lab, and this is his initial image. So you can see, of course, that his LAD is occluded. And as I've gained a little bit more experience, I can tell now, of course, just looking at this lesion, that there's a heavy thrombus burden probably associated with it. But essentially, he went on to have routine primary PCI. And you can see that, indeed, we've restored essentially epicardial flow through the LAD. But it probably doesn't project that well with the lighting in here. But if you look at the arrow here, as the dye clears from the vessel, you see this halo here of persistent dye that's sitting in the microvasculature. And this is an abnormal myocardial blush grade, which suggests that we have microvascular congestion and reperfusion injury. And indeed, this individual, this is his EKG 3 days after his MI. So you can see he still has persistent ST elevation and went on to have a significant infarct. So again, it would be best if we could redefine successful reperfusion as not only epicardial patency, but preservation of intact microvascular function, essentially. So this leads us then to the concept of door to unload. So when we look at door to unload, excessive myocardial oxygen demand relative to supply is essentially the fundamental mechanism underlying myocardial infarction. So with that in mind, if we were able to unload the left ventricle by mechanical means, for instance, perhaps we could minimize oxygen demand, we could reduce infarct size, and prevent subsequent heart failure for patients. And this is a similar concept to the surgical approach to STEMI management in shock, for instance. If for whatever reason someone having an acute infarct had to go for an initial upfront TAVIS strategy, we know that surgeons will first place the patients on pump to unload the ventricles. They'll take their time to harvest the graft and then subsequently provide reperfusion, and they buy into this strategy. By contrast, and to no fault of the PCI world, this is not our focus. Our current climate is essentially on ASAP, rapid coronary reperfusion for patients. And that's partly because we don't have a clearly proven, easy-to-do method to reduce reperfusion injury right now. So really, we go on to reperfusion as soon as possible, and there's very little time there to provide cardioprotective therapies prior to revascularization. So door to unload in preclinical models has actually worked out quite well. So whether it's in dogs, whether it's in sheep or pigs, as recently as 2008, if you mechanically unload the left ventricle of these animals during their ischemic period prior to opening their vessel, you do reduce the infarct size and you reduce subsequent heart failure onset. And there's also been biologic plausibility coming out of these animal studies to support this, whereby, for instance, when you do this, you seem to activate cardioprotective signaling programs such as decreased degradation of SGF1 alpha, which is a cardioprotective cytokine, for instance. So this leads us then to how could we potentially apply this concept in human beings. So one of the ways that's been proposed and been studied, which I'll come to, is the use of Impella devices. And the more recent one that we use is essentially the Impella CP. Impella devices are percutaneous mechanical circulatory support devices. They're a series of microaxial pumps, and as you can see, they're available in several different iterations, essentially with various levels of support that are provided. There's also an RV device that's available. And this is the basic construction of an Impella device built on the model of a pigtail catheter, where this pigtail sits in your left ventricle. You have your inlet for the microaxial pump here that sucks blood from the LV, and then it is subsequently ejected through the outlet of this pump into the aorta. And these devices provide up to about 4.3 liters of support, typically closer to 3 liters. Mostly these are inserted in percutaneous femoral fashion, but there are other options such as femoral cut down, axillary insertion, etc. Just to give you briefly an idea of how this works, this is the sheath that you eventually place in the femoral artery following serial dilation with the Impella-specific wire in place, and then you ultimately feed the device kind of in a Seldinger technique over the wire up to the heart, and this is what you end up with here. So this is your Impella pump sitting in your left ventricle, blood inlet and outlet up here in the aorta. So when you put these devices in for patients, what do they achieve in terms of physiology? So Impella devices unload the left ventricle. Of course, then they reduce your LV EVP and your LV wall tension. They decrease the work of your left ventricle and your myocardial oxygen demand. They increase your MAP, your diastolic pressure, your cardiac output, and your systemic perfusion is improved as well as your coronary flow. Your pulmonary capillary pressure is declined, and there's a secondary reduction in RV afterload. And this is something that's been looked at with pressure volume loops, for example, but in computational physiologic modeling, this is what this particular series of loops is from. Basically here you have your usual situation. This blue loop here is supposed to represent acute heart failure, and your green loop represents your Impella device. So you can see the overall area of the pressure volume loop where your stroke work is decreased, and also there's this obliqueness to the line here in your isovolumic phase. So this reflects the fact that the Impella device is constantly unloading your left ventricle, for instance, in comparison to ECMO, which is not doing that as much as I like ECMO. So you think that maybe Impellas are kind of a neat thing. We'd like to study them for door to unload and all sorts of other reasons, but unfortunately they're met with all sorts of criticism, and why is that? Well, it's not unfounded, unfortunately. So when it comes to randomized data in Impella, and also in terms of its lesser cousin, the balloon pump, basically randomized studies have turned up empty-handed for altering heart outcomes for patients. This was recently summarized quite nicely in this editorial paper written by Manesh Patel in response to the recent Door to Unload article, which I'm going to be going over. But for instance, if you look at previous studies in acute MI patients who did not have shock and who received unloading with balloon pump, there was essentially no change in major outcomes like MACE or reocclusion of the vessel, with the exception of one more remote trial from the 1990s. Similarly, in acute MI patients with shock, whether you unload them with tandem heart device versus balloon pump, Impella 2.5 or CP devices versus balloon pump, all in all, you're not achieving any significant differences in the 30-day mortality rates for these patients, although in the short term with your right heart cath in place, you will see improvements in your hemodynamic parameters, for instance, your cardiac index, et cetera. As well, in the high-risk PCI cohort, these devices have been looked at, be it balloon pumps or Impella, and again, unfortunately, there's no significant change in major outcomes for patients with these devices. So why do some people continue to firmly believe in these devices, and why do we continue to study them? Well, the reality is, despite the randomized data that I just touched on for you guys, there is significant registry and retrospective data out there in support of these devices that fuels ongoing interest in them. And then there's a lot of positive local experience at certain centers that, again, continues to fuel the interest in these devices. For instance, this is just a snippet from a news article released from TCT just this year. And one of the big proponents of Impella is Dr. O'Neill with Henry Ford in Detroit. And this is just a little interview with him where he's talking about some of the Impella quality database results, for instance, that have shown since the FDA approved Impella in cardiogenic shock, survival rates have improved for acute MI patients with shock by about 24%. And there's also this physician-led National Cardiogenic Shock Initiative where physicians use what they call a best practice approach, where they unload patients with Impella prior to PCI in a shock setting. They aim to reduce their use of inotropes, and they use more hemodynamic monitoring, or essentially more right heart cath. And at least, for instance, in a series, again, that was spoken about at TCT by Dr. O'Neill, he's had good experience with this, for instance, with 77% survival to discharge for patients and 99% native heart recovery. There's also been some enthusiasm for the use of Impella prior to PCI in unprotected left main culprit lesions in patients coming in with shock. There's been improved survival compared to when you put the device in afterwards, for instance. And there's also some more remote publications by Dr. O'Neill's group from 2014 where, again, acute MI with cardiogenic shock getting Impella prior to PCI versus after having improved survival to discharge. Recently, this small study was also published, the Impella sort of concept, basically showing that if you vent the left ventricle with Impella for patients who are supported in significant heart failure on ECMO, there seems to be some benefit in terms of improved survival, improved weaning, et cetera. However, this study can be highly criticized for a number of different reasons, such as its selective bias, et cetera. So regardless of all of this, the pros and the cons of Impella, the reality is that they're being used quite a lot in the real world. And this was a publication from Europe in 2014 from a working group there that was trying to develop best practices for Impella. And you can see in green, in green, there were a number of people using it for protected high-risk PCI, and certainly many people were using it for dark blue here, which was support in acute MI and cardiogenic shock. And at the time of that particular publication, over 8,000 patients had been supported with these devices outside of the U.S., and at over 800 U.S. hospitals, over 20,000 patients had been supported with Impella, and this was back in 2014. So looking at this concept then of studying Impella further, we come to what's kind of hot off the press, so to speak, in door to unload, which is the publication of this door to unload pilot study using the Impella CP device by Kapoor et al., which just came out. So I'm going to go over the study in a little bit more detail because this is kind of where we're at with the data right now. So this was a multi-center prospective randomized exploratory safety and feasibility study. And basically you had patients coming in with acute anterior MI, and all of those patients received Impella CP devices. Then they were randomized either to receive a period of waiting prior to undergoing coronary revascularization, or they went on immediately to have their coronary revascularized. So again, they were coming within about 6 hours of their chest pain onset with acute ST elevation. Importantly, they excluded patients in shock, so this was not a shock trial. This was STEMI patients without shock. They excluded patients where they couldn't put an Impella device in, patients who couldn't have cardiac MRI because that was how they were going to evaluate infarct size, and they excluded people with previous MI or CABG, so it's a little difficult when we think of the fact that a lot of our population would have certainly had previous infarcts, et cetera. In terms of their primary safety outcome, this was a composite of MACE, including CV mortality, reinfarction rate, stroke, or major vascular events at 30 days. They also looked at additional safety parameters, many of which are relevant when you're thinking of Impella devices. For instance, they looked at hemolysis, ventricular arrhythmias, bleeding, and minor vascular events. And then their primary efficacy endpoint was infarct size as a percent of the total LV mass at 30 days according to CMR. They also looked at the infarct size at 3 to 5 days with CMR. And they looked at some other exploratory endpoints with CMR, and they stratified their results according to your degree of initial ST elevation, for instance. So essentially, this is just a schematic of the trial. Basically, again, you have patients coming in with acute anterior MI. They all get an Impella CP put in. And in the delayed revasc group, basically they undergo primary unloading of the left ventricle for about 30 minutes or so, and then they get their angiogram and their PCI. The other arm over here gets their Impella put in, and then they undergo immediately their diagnostic angiogram and intervention. Ultimately, 10 patients ended up being excluded predominantly for reasons where they couldn't tolerate MRI, and there were a couple of deaths as well. So ultimately, 9 patients had analysis at that 3 to 5 day mark for cardiac MRI, and then, 9 patients were excluded at that time, and ultimately 10 were excluded by the time they did their analysis at 30 days with CMR and their MACE analysis. I'm not going to go over this, of course, but this is just the patient baseline characteristics, which were not significantly different between the two groups. So they successfully implanted these Impella devices in all comers, and they achieved adequate flow with their devices, they felt, to represent adequate unloading of the left ventricle. And these are the results in terms of timing elements. So in terms of their door to balloon time, this was intentionally different between the two groups, and they did achieve that. So in the delayed group, which is the UDR, so D for delayed, the door to balloon time was approximately 97 minutes. In the immediate revasc group, it was approximately 73 minutes, and this was significantly different. The door to unload time, so the door to getting their Impella put in, was no different between the two groups and was about 60 minutes or so for both groups. Now, the time from symptoms to unload, so symptoms to Impella being put in place, was not statistically significantly different between the two groups, but interestingly, there was a bit of a longer time period in the immediate revasc group. So this is one of the criticisms of this study, which I'll come to, that, you know, maybe despite randomization, these two groups were a little more similar than you would have liked them to have been. In terms of the insertion time for the Impella device, it took about 15 minutes in both arms of the study. And again, the time from unload to ballooning was significantly different between the two groups because that was intentional, so about 34 minutes for the delayed group versus about 11 minutes for the immediate revasc group. And patients were supported for similar amounts of time in both groups, between 5 to 8 hours. The procedural characteristics for the interventions between the two groups were essentially similar. All patients received drug-eluting stents. So in terms of their results for infarct size, according to CMR, by 30 days, there was no significant difference in the mean infarct size between the two groups. Now, it was numerically lower in the delayed revasc group, but it's important to focus on the fact that this is not a statistically significant difference, nor did the ejection fraction differ significantly between these two groups. When they looked at their 3 to 5 day outcomes, again, infarct size was no different between the two groups. and neither were any of their other CMR parameters, for instance, looking at infarct size as a portion of their initial area at risk. In terms of their adverse events at 30 days, again, no significant difference between the two groups. In terms of safety parameters, these did not differ significantly between the two groups, but it's important to keep in mind that there were some of these events occurring, for instance, hemolysis, ventricular arrhythmias, and minor vascular events, many or most of which were related to your Impella access site. So that is important to keep in mind as we discuss this a little further. There was also bleeding that was occurring in these patients. It did not differ significantly between the two groups, but there were patients experiencing BRAC2 or more bleeding, as is shown in this table. When they stratified their results according to initial degree of ST elevation, there was no difference compared to their non-stratified results. So in terms of this trial, essentially at the end of the day, one of the biggest criticisms of it is that it simply lacks a standard of care control group. So we don't have patients here who are coming in for primary PCI without unloading of their left ventricle. So that really limits our ability to understand the safety of this approach, because we can't really say with confidence that there's no penalty to waiting here because we don't have that comparison group. So we don't know if these patients, say, with the bleeding that they had, the vascular events that they had, if that is worse in comparison to patients who wouldn't have gotten Impella, for instance. I think this study also brings to light the challenges that we see in translating animal studies to the human side, for instance, where in the human world we're dealing with a lot more heterogeneity in our subjects, all the comorbidities that humans bring with them, differences in the timing and types of infarcts that they experience compared to infarcts that we induce in a controlled laboratory setting. As well, infarct size, while important because it can correlate to later heart failure, it is not in of itself a clinical outcome. So looking at endpoints such as death or heart failure, for instance, might more readily motivate interest in pursuing such a therapy. There's a lot of criticism of undertaking this study at all and of undertaking studies of Impella in general, as I said, but I don't think it's wrong to consider new ways to improve STEMI outcomes. I believe it's probably too early to write off the door to unload concept, and we need to wait for the impending larger trial that is going to be done with the proper control arm. That being said, you could spend a lot of time having this debate down here as to whether this is the best way to invest our time and effort versus, for instance, investments in better upstream care, patient education, enforcing optimal medical therapy among physicians, access to cardiac rehab, dietary improvements, etc. As well, there's some issues with the practicality and buy-in of the store to unload approach, of course. So there's expense associated with it. So for instance, if it is going to be done with Impella, I'm Canadian, so you know Impellas are expensive, and this is an issue. Time consumption and cath lab throughput. Well, people in this trial were fairly slick. They got these devices in 15 minutes. If you're a new center starting with Impella, you're likely going to take longer than that, and in general, it will slow your cath lab down. I'm not saying that's wrong, but it's a consideration. Vascular access challenges and complications, we see that these did occur with the use of Impella. Whether or not they're a big issue compared to a control arm remains to be seen. There are subacute device complications like hemolysis, etc., interference with the mitral valve, arrhythmias, what have you. And there's this previous lack of support from randomized data when it comes to Impella-based interventions. So really you would need compelling clinical outcome impact data in larger, properly controlled trials to motivate any broad uptake of this particular practice. So at the end of the day, these are my concluding thoughts. I believe it's important to, number one, be proud of how far we've come in STEMI care based on what I was describing earlier. Number two, not waste time chasing the wrong things. And this is not directed at Impella. I'm actually very open-minded in both respects when it comes to Impella. But I think it is right to critically appraise the approaches and technologies that we're studying. So I think that's important. And then thirdly, I think it's important to keep an open mind so that care innovation can continue to evolve and so that we don't stagnate. So it's important not to be dogmatic about these things. So at the end of the day, have we hit a wall when it comes to STEMI outcomes? I think this remains to be seen and only time will tell. Thank you.
Any questions?
Allison, great job. That door-to-unload concept as the next step, I think it's provocative. And I'd ask Jay, who's got a lot of experience in the STEMI world in this kind of space, what your thoughts are on this. I mean, I have reservations on this. This study, to me, tells me that it's safe to wait 30 minutes with an anterior MI if you have an Impella in versus not. But other than that, it doesn't tell me anything else. Complication rate, vascular's there, ventricular fibrillation's there. But there's that concept which can be proven later on. But see what your thoughts are.
Where to begin? I was actually in the audience when they presented this, and the commentator, you know, it was a late-breaking trial, so each study has like a 5-minute commentator from some expert. And I forget his name, he was from Germany, and he was very kind not to really skewer the study, which it deserved to be skewered, because of certainly the lack of a control group. The other thing, some of the other things he talked about, you know, when you look at infarct size and ischemic time, you know, they were on the asymptote. They missed the whole early part where if you intervene within the first couple hours, I mean, you're almost out to 3.5 to 4 hours when you look at the total ischemic time. So your chance of making a significant difference, you know, gets smaller and smaller as your ischemic time gets longer and longer. The other question is how does this, you know, you talked a lot about reperfusion injury, which is something we've been interested in for a long time and just finished a big post-conditioning trial. But how do you think it really affects reperfusion injury? I could see how it maybe reduces ischemic injury because you're reducing oxygen consumption and wall stress, et cetera. But you know, you mentioned all these like 5 things, you know, about you know, thrombus burden, embolism, microvascular dysfunction, things like that. How do you anticipate that unloading would affect those things that that contribute to reperfusion injury?
Right. So I think that is a complex question. I think there's thoughts that it might, in the sense that you're resting the left ventricle, and maybe some of that kind of inflammatory cascade that's happening may be mitigated by doing that. But pathophysiologically, I wouldn't be able to tell you exactly in which fashion this is going to impact reperfusion injury, but it is one of the concepts that's mentioned as one of the potential benefits of a door-to-unload strategy. I think we need more information as to exactly whether that would work.
Right.
Yeah.
The other thing, you know, you mentioned their paper in JACC where it was in, I think it was in pigs or dogs. I forget which animal it was.
It did reduce infarct size.
Where it showed a reduction in infarct size, but if you looked at the volumes, they were scary big in the Impella group, and it's just like, well, that can't be a good thing to have 30 or 40% increase in end diastolic volume compared to the group that got unloaded. So that really didn't make much sense. The other thing I would add is, just going back to our post-conditioning study, we found absolutely no acute benefit on infarct size or myocardial salvage, but then when we looked at a year, there was a significant improvement in remodeling in the group that got post-conditioning. So, you know, maybe some of these effects you may not see acutely, and so I would just say hopefully it'd be important for this study when they do it to look out longer term, like out to a year, and not just look at the first 30 days.
For sure.
So.
And I did forget, actually, I had mentioned as well, there was at least one signaling, cardioprotective signaling pathway that was favored when they were doing this therapy in animal models. So I guess that's another part of that consideration of why it might help.
Right.
Yeah.
Allison, congratulations. That was an excellent study, and we actually created a circulation, and it was a very thought-provoking discussion, because many people said exactly what you said, is that there's no control group. How can you conclude it's safe? In the early versions, they were saying this is, so the approach is safe, but if you don't have a standard of care, how can you say it's safe? Having said that, everything that's been tried so far, as you said, nothing has been shown to improve mortality or elevate remodeling. So it's been one of those areas that many drugs, many areas, nothing has really panned out all these years. And of course, the bar is fairly high. What do you think would be the design for something like this going on forward? What studies should they do to make it more practically relevant and show a signal of clinical benefit?
So I think one thing is, well, some of this is easy to answer because there's the initial plan that they basically need to do the study with the proper control arm. So that would be number one. I think as well, focusing on the right kinds of outcomes and the right duration of follow-up, as Dr. Travers alluded to. So basically looking at longer-term outcomes for these patients and looking at hard clinical endpoints as opposed to simply infarct size at a 30-day time point, for instance. The other big question, and we don't have any answers to this at the moment, is are there other ways that we could look at unloading the left ventricle apart from Impella devices? And that's, I mean, there's probably only so many ways to do that, but it might be something to think about. Can we actually come up with better devices and easier to use devices, you know, that can be inserted to help with this concept? Yeah.
Maybe I can ask the Sharkey person. But then I'm curious Dr. Ekman's thoughts on this, because you know, we had a discussion in the Journal Club last week about Impella.
That was a very nice, balanced discussion, so thank you. As you pointed out, the balloon pump data does not show any benefit to unloading the left ventricle. What I'm wondering is, how does the hemodynamic effects of Impella compared with balloon pump with respect to the LV diastolic pressure and the coronary perfusion pressure? Is there any information on that to guide us as to why Impella might be better than balloon pump?
Fair enough. So I think essentially you're supposed to be getting more effective on loading with the Impella device compared to the balloon pump. It's essentially a more potent pump, basically. So I would imagine that the relative improvements in parameters like your LV and diastolic pressure, et cetera, are going to be incrementally better with a with an Impella device compared to balloon pump. But again, in randomized studies, neither device has panned out. So
what does happen to the diastolic pressure?
So it's decreased.
By how much?
That I can't tell you. I do have that pressure volume loop there if you want to take another look at it, but that's a predicted model based on computational physiology, essentially. That's what it's supposed to do. Whether people have actually, and we got into a debate at this at our last sort of ECMO Journal Club, like whether people have actually sat there and done these hemodynamic measurements in the real world setting and documented these changes. I'm not too sure that they have, or at least not extensively, but those pressure volume loops that I presented were based on computational modeling, for instance. So whether that actually pans out in real subjects, I don't know the answer to that. It should be easy to do, you would think. Yeah.
Allison, great talk. I think that I just wanted to echo what we recently discussed about this study in a different setting in the ECMO meeting. What Dr. Reno had said, that I think this study is a good starting point. I don't think that it really clinically proves, as you just said, but I think that you know, people know how obsessed I am with unloading the heart and how important I think it is. I think that we basically just not at the point where we can prove it because of the device limitations. I would say I'm 100% sure that in the future unloading the heart will be absolutely the most important part of the clinical to get a better clinical results. We're just not there yet because of the device limitations, and I'm sure it's coming. So.
Allison, can you tell me how this device is being used? Like, are you using it just during the procedure? You're done. You take it out. How's this work?
Right. So it depends on the clinical setting. So it's being used in all sorts of different ways. So one of the ways that we use it is high-risk supported PCI. So for a lot of those individuals, the device will go in at the beginning of the procedure, and they will be weaned and have the device removed prior to leaving the cath lab. If the device is inserted in the context of cardiogenic shock and acute MI or otherwise, more typically the device is left in place. It's formally approved for 6 hours of use. However, it is often used longer than that, and it is often weaned more promptly than that. It just depends on how the patients do and what the end plan is for them, such as escalation of support, or they're doing great and you get the device out. But the two common settings that you would see would be using it transiently in the cath lab for supported high-risk PCI, or putting it in and leaving it in for X amount of hours in someone who has a shock picture concurrently.
So just a follow-up comment. I think this is the important thing is to figure out how long you need support. Many of us have protocolized ways on how we wean our temporary support. Just like Carl's saying, I mean, our whole practice in cardiac surgery is unloading the LV. I mean, that's what we do. I think we need to tease out
how to use this device better? Does it need to be left in longer? Does this LV need more time to, quote, recover? Anyway, great talk.
I just want to make a great talk, Allison, and I think really hot topic. As you mentioned, we talked about it last week as well in ECMO Journal Club. But I think we actually have an opportunity here to look in a little bit of an indirect way what is really the influence of loading, because we do use ECMO in patients with STEMI, and obviously a little bit of a different population. We usually use, we use ECMO when patients are in shock, but we're actually loading ventricles. And we do have a subset of patients that were vented during ECMO. And I think, we say ECMO saves lives, and clearly I'm a big proponent of it, but it's hard to tell what would happen if we could maybe, unload these patients who are on ECMO, what would happen to the infarct size. And we have quite a significant number of patients that move from ECMO to an LVAD. So we actually, as a result of this study, we thought, and based on last week's discussions, we thought we're going to now possibly identify patients who are at risk of left atrial hypertension and clotting left side heart, and we will put Impella kind of prospectively in a way in anticipation of badness. And I think that would be a really interesting group of patients. And the other thing, speaking of microcirculation, so there is some data on patients on ECMO and microcirculation in a setting of acute MI. And then, again, it's a historic control, or these are patients who are versus non-support on ECMO. But it's significantly diminished, and it was just published recently in JSIO, looking at the sublingual circulation on ECMO, on and off ECMO. So,
sorry, just one question. These things that are analyzed by CMR now, that we have infarct sizes and all these fancy things, obviously to make some sort of statistical difference and to give the company the chance to sell the device more, right? It's very much supported by the company. If you have 5%, let's say at some point you have 500 patients in there, and the change in EF of 2% or the infarct size of whatever 100 milligrams is going to be significant once you have enough, data points. How much do we actually know how much myocardial salvage in a CMR data set we need to see actually, let's say, quality of life improvement or something like that? Or do we always have to say mortality, for example? Or, what is an endpoint that really justifies another $30,000? And, if you have one death because of an aortic rupture because you had another 14 French, device put in. So how much, I just can't figure that out right now. That's why I'm kind of against it. I'm just thinking, how much complication will I have for what endpoint that is statistically but also meaningful to the patient? I'm just not sure. Maybe I don't understand the studies yet.
I think, first of all, I want to say that this was really an outstanding talk, Dr. Hall. Thank you for your great summary. The couple of things that I think about with this are, number one, I think the timing is important, and we talk about the unloading a lot in the ECMO patients, and I do worry that, for example, we often give people a trial of a few hours where, let's try balloon pump, let's try dobutamine, let's start nipride. We might be missing a window of opportunity there. I think the other thing that I struggle with is some centers are using, for example, a bipella strategy more often than ECMO. Now, there are clearly some patients that need the sort of nuclear option of full support with ECMO, but who are the patients that would be better served with what would potentially be a more effective unloading strategy? And I had the pleasure of preparing a talk on pressure volume loops for the ELSO conference. Thank you, Dr. Renowitz, for inviting me to put me back to my med school physiology. But it was that when I went into that thinking, I think this is a technology that's where the marketing is leading the science. But the more I looked at the pressure volume loops and thought about the physiology of it, I have a hard time dismissing the fact that the underlying physiologic rationale for it is pretty compelling, and wonder, are we just not using it right? Are we not selecting the right patients? So I think this is an area we're still going to hear a lot more about. I don't know the answer, but I struggle a lot with who should get ECMO versus who should get Impella. Obviously, our institutional practice here has been more towards ECMO, and it's hard to argue with the outcomes that we've had, which are superior to what's been reported in international registries. But I think, to me, those are the things I struggle with, is there's a lot we don't know about the timing and about who are the right candidates. And I couldn't agree more about the endpoint argument. I mean, if the whole, I loved how you started with, now people aren't dying acutely of arrhythmias, but now they're all getting heart failure. To me, that's obviously an endpoint of interest.
Mm-hmm. Yeah, and there was that one statistic I brought up. I mean, how robust it is, I'm not sure, but basically for every 5% increase in CMR and infarct size, they were saying 20% increase in your rate of one-year hospitalization for heart failure. Whether 5% is the number, I'm really not sure, but I think that's the whole point you made, sort of calls us to focus on more clinically relevant endpoints with some of these larger controlled trials that are supposed to happen. So.
Other questions?
One more comment, just hopefully people will still find this discussion of interest. We've just recently learned that Dr. Kapoor from Tufts, who's done a lot of the basic science work on this, will be joining us for grand rounds in April. So we'll have a chance for everyone to sharpen their knives and arrows to have what I hope will be a fantastic discussion, because he's running a basic science lab with this too, and has a lot of great preclinical data as well as experience, and he's, as I understand it, dual boarded in interventional and heart failure, which he's kind of a rare bird in that respect.
All right. Thank you, Dr. Hall.